very thankful that you're spending time while we discuss widening the gap, health disparities in a time of COVID-19. Again, my name is Desmond Banks, and I'll be your presenter for today. I'm an online adjunct instructor within the Department of Community and Environmental Health. All right. So the presentation outline is going to go pretty simple as follows. Just have a few questions. We're going to explore what is the data, why is the data, how can we use the data, and the fourth question, what additional data do we need? And again, these statements or opinions are purely my own, and so does not necessarily represent those of the department, so you can't get mad at them or try to sue them if I say anything that I'm not supposed to say. All right. So what is the data? One of the institutions that has been doing a lot of analysis on COVID-19, it's no surprise, it's Johns Hopkins. My alma mater, obtained my Ph.D. in public health policy from Hopkins in 2015, and they have a great breakdown of what states are reporting regarding racial data transparency. And this data is up to date as of today. And so what they really do here on their website, here's the URL here at the bottom, they provide a kind of a description of what states are reporting and how they're reporting it. So we have 38 states that are reporting data on confirmed COVID-19 cases, 33 states which are presenting data on death, and however, only 2 states which are presenting thus far, according to Hopkins, test data on testing, and those states are Kansas and Illinois. All right, so this slide just really talks about what is data availability. Again, the source for this is the Johns Hopkins University of Medicine Coronavirus Resource Center. Okay, and as I stated previously, only 2 states have released data on COVID-19 testing, cases, and deaths. All right, those are Illinois and Kansas. And then to order to evaluate data effectively, you really need data on all 3 of these elements. You need data on testing, cases, and deaths. And failure to evaluate COVID-19 testing data could lead to skewed results. For example, if you have a higher number of cases and/or deaths in population A versus population B, this could be attributable to a disproportionately higher number of tests conducted in that population. So it's really hard to get it differences in data, especially as cases or deaths, if you don't have complete information regarding testing. Again, talking about the data, in addition to having elements on testing, cases, and deaths, you also have to make sure that the data that you're looking at is representative. You want to make sure that you have a representative sample. And a good way to understand, I know we have varying degrees of education on this subject, so within the webinar today. So when we're talking about a representative sample, all right, one question is how well does this sample represent the overall population? And some of the areas that you want to look at is regarding age, sex, race, ethnicity, education, and income. And this is important because a representative sample is going to lead to high external validity, and that's going to lead to generalizable results. Okay, and so when you have a representative sample and high external validity, you can have generalized results. And some of the 2 statements that kind of help you understand is that this sample or subset of the population is representative of the overall population. So we can conclude that the data and outcomes for this sample or subset of the overall population will be generalizable to the overall population. So we're looking at a small sample of it, but we're saying that this is, even though we're not assessing everyone, it is generalizable to everyone because this sample is representative of everyone. All right. And so looking at the 2 states that we had Kansas and Illinois. And so in order to make sure that we have a representative sample, we want to make sure that we look at some of those demographics that we discussed earlier, right? With age, sex, race, ethnicity, education, income. So this is just a snapshot from our census.gov, real-time census.gov. Quick facts, great information there, great demographic, socioeconomic information there. Here in the farthest most right column, you see there's the nation as a whole, United States, and then we have, the states that had testing, Illinois and Kansas. And as you can see, as far as, age and sex, fairly representative to the nation as a whole. But when we go down to race and Hispanic origin, we see differences here, right? For instance, the state of Kansas, just 6% of residents are Black, and if, compare that to the nation as a whole, it's about half of the national average there, and it's similar with Hispanics, much lower than compared to the national average. But if we look at Illinois, really across the board here, as far as race and ethnicity at least, fairly comparable to the United States. So we would say that of the two states here, that this is a fairly representative sample that we'll be able to generalize the results to the nation as a whole. All right. And so in developing this webinar, I was, stuck with Illinois here, and that, even though we race ethnicity, that's just one of the criterion, right? We have others. So I wanted to, again, using these census, .gov data, just to try to look and drill down and make sure I wasn't missing anything that would, kind of skew those findings a little bit. So look, again, foreign born persons, very, very similar. Home ownership, very similar. Gross rent, mortgage costs, living in the same household, language other than English, even such things as computer and internet use. I mean, this is, very, very relevant right now with the concept of the digital divide with schools and our university in itself being impacted by, we're all working remote now. And if you have, especially primary and secondary school age, individuals, your family, and you have 2 or 3 or more children, and you have, one computer, or you don't have any computers, or you don't have access to the internet, how are you going to stay ahead? How are you going to stay up to date with your education and just, information overall? But we see throughout the state of Illinois, fairly representative of the United States on a lot of, in addition to the race and ethnicity, on the other outcomes here. Okay. So, in looking at that, I went over to the Illinois Department of Health. Now that we have a representative sample, okay, I want to go over and check out their, public health website, because they're, looking at data by race, ethnicity. And again, I apologize, this is kind of, biostatistics 101, but I just want to kind of look at some of the numbers here. Again, this is as of April 23rd, right there on the website. A number of cases, looking at the incident rate. Just want to kind of get a feel for what it looks like within the state and within the nation. And since we said this is a generalizable population. So incident rate, 21%, about 1 in 5 individuals are infected with COVID-19. Fatality rate, close to 1%, a little bit less than 1% nationwide. And we also have the case fatality rate of those individuals who are infected who ultimately end up passing away. And for these numbers, as you know, is very, very relevant with policy. Right now, you have various, each state in their own autonomous fashion making recommendations or making policy choices based on these data. I mean, you can see these are very, very different numbers. You can say, hey, well, 1 in 5 individuals are impacted by COVID, and someone could say, well, the fatality rate is just at 1%. And so you really have to balance the science, balance the public health data with what's going on within your state, right? And these are just aggregate state numbers. So different parts of the state where these numbers could be very, very different. It's just we're in really challenging times, and I applaud all of our leadership, both federally and at the state level, for taking this data and consuming it and making policy recommendations based on it. All right. So in looking at the data, after I came statewide, I decided to go to the Illinois website. This site, this should look familiar. This is the same. This is the Illinois Department of Public Health, one of the 2 states that present data on COVID-19 by race, ethnicity. So I want to check out the site as I'm developing a presentation and say, hey, what do we have here? So I go down to race demographics. All right, I want to look at data on testing, and I was a little taken aback. As you can see here, we have whites. This is just on race demographics on COVID-19 testing. I don't want to go too fast. I just want to make sure that We're on the same page. COVID-19 statistics, the same one I did the incidence and the fatality rate and case fatality rate. Saying, have they updated this yet? Nope. So we're getting real time. This is present as of the most currently present data available. So I scroll down, race demographics, and my notes were tested. Okay. Half of these fields are blank. I don't know why this is. As all as you know, we're as public health scientists, usually the demographic data is some of the most usually readily available. It's usually some of the other information, such as education and income. That's a little bit harder. I don't know why, and this is not a slight against the Illinois Department of Public Health at all. I'm just, they're only one of 2 states who've even presented this data sort. But this makes it really challenging as we can go back to our slide here as we let's see if I get back in the presenter view, and let's see if I swap that out. Right, going back to the slide, is we need data on all 3 that to really show. We need data on testing. Let me go back down. Here we are. We need data on all 3. So like data effective, we need. So if we're missing half of the data that we need on race, ethnicity as far as testing, it's really going to be hard to evaluate. This is going to be hard to make a conclusion if we're missing 50% of the data on race as far as just testing. And so so that's the first thing that kind of stuck out at me. The second, I want to look at, we talk about being a representative sample, and here's the U.S. Census Bureau. This should look familiar. This is what I pulled for Illinois. So if we can scroll down and look at, about 76%, and the same as nationwide, 76%, 3/4 of the population is white, 15% Black, and about 17% Hispanic. So we got 75, 15%, 17% here. So let's look at some of the testing data. Now, granted, it's going to be skewed because we have some of this, it's left blank, but we can see that this isn't 75%. This is far below just on the testing alone. And in biostatistics, there's a number of different things you can do with the blank data. You can, hopefully you don't want to admit something that's this large, but you can try to apply it to the, larger population, do various analyses there. But, Blacks is a little bit, closer to that figure, to that 14% figure, and then Hispanics are lower. So right now, this is to be really challenging with such a huge subset, huge part of the population being just, not having race data on testing is going to be challenging. Okay, so after, the test, want to look at, just case data, want to see if they look any different. Again, a quarter of it, 25%, we don't have data on race, ethnicity. Not as bad as the testing with the 50%, but still it's relatively high considering that this is some of the just basic fundamental information that we rely on in public health. But for whites, it's fairly similar as far as the consistency between the testing and the confirmed cases, even with the blanks that's left there. But for Blacks, we can see it's higher. We can see almost 24%, and the same with Hispanics. So if we go back to the testing, just looking at the ratios, 13%, among Blacks, and 6%, among Hispanics, and going back and looking at the cases now, much higher. So just for instance, for Hispanics, about just 6% of the tests were among Hispanics, but 3%. There's about a 3-fold increase. 18% of the cases is also Blacks as well. And so I, as I was trying to put together this presentation, I really didn't know what to do with that, right? Let's see if I lost my view here. Okay, I didn't really know. As we're just looking with a lot of absent data, and so I said, well, let's look and see what we have on deaths. More data. Only about 5% is left blank, and then here was really see some things get interesting. So we have about 37% of the deaths in Illinois due to COVID-19 are among Blacks, and about 40% due to whites. And if we go back to the Census Bureau data, and we're just looking at race and Hispanic, well, Blacks only make up 15% of the population, and yet, so 15% of the population here on the census data. Just scroll up so that Just quick facts from US Census Bureau. So just represent 15% of the population. Yet, if we go to for Illinois, 37%. That's well over twice as much as where have whites, or 40% of deaths, what makes up 3/4 of the population in Illinois as a nation as a whole. Interestingly, Hispanics have a much lower rate compared to their national average. So nationwide, I'm sorry to make you dizzy going back and forth, but I just want to try to drive that back home. About 17% of cases of population Hispanic, yet for deaths in Illinois, it's only 11.8%. So we definitely have something going on here, and so there has been a lot have been said. What's the cause of these disparities? But when you really look at the data, what really jumped out to me is not necessarily the disparity among blacks compared to whites. It's really blacks compared to Hispanics. Really, when we look at a lot of the morbidity and mortality data throughout the nation, which Health Disparities field was founded on, is usually that blacks and Hispanics will have kind of parallel in their rates of morbidity and mortality. And we're not seeing that here. We're not seeing that here. That is really, this is a phenomenon that really just kind of, I just thought was striking. And so I really just tried to, figure out what's going on here. And so, as not to skip over this, but at Illinois, they did such a great job of presenting this data. They have data by age. All right, so these are age groups, less than 20 to 29, 30 to 39, and so on, 40 to 49, 50 to 59, all the way to 80 plus. And as you can see, it's a general, and I also have it, broken down by race, but by age group, it's pretty varied as we expected. Very, very young have a lower testing, and the older, lower testing, but it's concentrated between that 20 to 50, 20 to 60 age range. That's tests, all right? Similar thing with cases. As you can, that would make sense, as we're going to be testing, you would expect that the number of cases would follow that pattern of, testing in cases. That makes sense. But we go to deaths. Striking. Fascinating. I mean, I'm going to the number of cases, okay? And the deaths are almost exclusively concentrated among individuals age 50 and above. It totally breaks the pattern of the testing and the cases, and you look at the deaths. Okay, now let's drill down just a little bit further on this. We're looking at blacks, whites, and also Hispanics here in brown. At age 50 to 59, blacks are over twice as likely to die compared to Hispanics. And as we go back to the census data, blacks only make up 14%. Hispanics are higher percent, 17.4%. But if we go here and look at this, twice as likely to die. And the testing data wasn't as skewed as that. So it's, what's going on with that? And again, we'll go to age 60, threefold. This age 70, well over threefold, and about 80 plus is almost fourfold. The ratio between, blacks and Hispanics. And it is just striking. And again, as I was trying to put together the presentation, usually I have a bunch of slides and, have talking points, but I just really didn't know what to do. I thought I found myself coming up with many more questions than answers. This does not fit the traditional health disparities mold. Again, when we talk about social determinants of health and health disparities, typically it's, blacks and Hispanics, mirror each other. And for this one, we're seeing it 80 plus blacks are nearly 4 times as likely to die from COVID compared to Hispanics, and with the testing and the cases are similar. So in Illinois, the cases are very, very similar. Hispanics and blacks, but there is not a fourfold increase. You have about 6,800 Hispanics compared to 8,800 blacks, but then you look at the data among the elderly, nearly a 54 to 191, and it just alerted me that something is going on here. And so I went back to some of my trusty resources. Individuals, again, will go to Hopkins Coronavirus Resource Center, And just kind of give us some background on health disparities, I'm going to read this for a little bit. That, the questions and answers on the health disparities in COVID-19. There are likely multiple causes for these disparities. Existing racial disparities and the rates of chronic medical conditions increase the risk among ethnic minorities for serious complications of the novel coronavirus, resulting in higher death rates. Additionally, the observed disparities in how the disease affects racial ethnic minority populations highlight inequities in socioeconomic status, living conditions, and access to care in the United States. Because many racial and ethnic minority persons live in poverty, they're experiencing this pandemic in a different way. For example, they may rely on public transit if they cannot afford a car, need to shop more frequently for basic necessities since they cannot afford to stockpile goods, and do not have health insurance or access to regular medical care. Social distancing may not be a convenient or realistic option for many because they may live in small multi-family apartments or home. Now, I agree with all this. I agree with the, there's been, decades of data which show that, health disparities persist. But when you look here at the death data, specifically among, the age groups, this is not consistent with that. A lot of the social demographic factors will lead to social disparities, where you eat, where you live, work, and play, and are educated. Blacks and Hispanics, have those same factors, but as far as the death rates, very, very different. Very, very different here. So this is the traditional health disparities, social determinants of health argument doesn't hold here. I mean, when you're looking at, Blacks and Hispanics here, very, very exacerbated, and especially when you look at the in the older age groups. So just looking at this, it's and here too. Here, the traditional, where the social distancing and the other factors about public transit and going to more. I mean, they're not. You would expect to see those here as well, and you just don't. And we know health, disparities exist. It's just something from the Centers for Diseases from the CDC, and they're celebrating their 20th year. And so, just kind of a primer on health disparities. Just some research here in 2015 to 2016. Hispanics and non-Hispanic Blacks had higher prevalence of obesity, 47%, 47% in 2011, prevalence of diabetes, 18% in Blacks, 17% Hispanics. This shows that mirroring of the data that I was indicating, that Hispanics and Blacks both suffer higher rates of morbidity and mortality compared to other races, but they mirror each other. They typically mirror each other. We're looking at obesity here and diabetes here, but we go back. This isn't mirroring. Blacks, 4 times as many, especially among older age groups. So this does not fit that traditional health disparities, approach to racial and ethnic gaps in health. There's something very, very different here. And again, I apologize if this is a little bit disjointed, but this was in real time, putting this, together, to make sure I gave you the most relevant data. So as I indicated earlier, I'm an online adjunct instructor, and I teach a course called Determinants of Health. And within that course, we talk about the social determinants, where you live, work, and play, how that affects health. But there's also a genetic component too. And so when I looked at this data, I'm thinking, well, there has to be something else going on here. It's not just those socio-demographic factors that we're talking about. They can't explain this. If these individuals have, similar rates of obesity and diabetes, why are, Blacks as across this age spectrum, when people start to die from COVID, why are they, experience such a higher risk of death? Is there, could there possibly be a genetic component? And looked at, things such as sickle cell disease, as we know, that's something where there is a genetic component. It's not an infectious disease, but it does show the impact of genetics, where sickle cell disease occurs about 1 in every 365 Blacks versus 1 in 16,000 Hispanics. So it just got me, thinking perhaps there is something, genetics involved. I'm not a geneticist, but just, thinking, and also looking at the data here, again, going back to the elder populations, especially here in Georgia and across the nation, these deaths are being concentrated in nursing homes. More and more data comes out shows that these are among older populations in nursing homes. So I just started to search, infectious disease within nursing homes, and I came across a great article here from the Journal of Health and Social Behavior, recent article from 2013. I'm just going to read this extract to you. Examining nursing home segregation and race disparities and the influence of vaccination, this article demonstrates that segregation may increase both susceptibility and exposure to seasonal flu for Black Americans. Evidence based on a 2004 U.S. National Nursing Home Survey shows that individuals in nursing homes with a high percentage of Black residents have less personal immunity to flu since they are less likely to have been vaccinated against the disease. They may also be more likely to expose to the flu since more of their co-residents are also unvaccinated. This implies that segregation may generate dual disease hazards for contagious conditions. Segregation appears to limit Black Americans' access to personal preventative measures against infection, while also spatially concentrating those people who are most likely to become contagious. Now, again, this is a novel COVID-19. There has not been a vaccine today, so there's not an apples to apples comparison here. But I was just trying to find any explanation for this. Why is the deaths concentrated among the elderly, and what is this disparity here? Just want to get some insights. Obviously, again, not apples to apples. It's not that these individuals aren't vaccinated against COVID, but it just got me thinking: is previous and putting together this presentation, I came with many more questions than answers. When one came to the head, this COVID previous influenza vaccination, is that associated? Is that it's sort of a protective barrier against death from COVID-19? Obviously not infection, right? But does that prevent against more mortality or just exacerbated health conditions? Again, just more questions than answers. And so I started to research genetics with the flu, and I found some enlightening information. This is from an article on genetics and flu susceptibility, why the flu is life-threatening for some and quite mild for others. Again, we heard about the various conditions, the symptoms of COVID, how it can be mild and fatal in others. And here's just an excerpt. Collectively, these data reveal that the action of a single antiviral protein, IFITM3, and I apologize for all of you infectious disease experts who, if I'm butchering the acronym, I'm not sure if it's IFITM3 or if that's how you pronounce it. Again, this is just all in real time. These data reveal that the action of a single antiviral protein, IFITM3, can profoundly alter the course of the flu and potentially other viruses in both human and mouse, explains Paul Kellum. To fully understand how both the protein and the gene control our susceptibility to viral infections, we need to study the mechanisms of the gene variant more closely. So again, this just leads credence to the idea that I indicated earlier about determinants of health, right? Because just the socio-economic phenomenon is not explaining this. It's not explaining how there's similar number of cases between Blacks and Hispanics of COVID-19, but the deaths are so much more concentrated among Blacks. The traditional health disparities contentions don't hold. So I'm just trying to find anything that shows, again, and the more I search for genetics with the flu and coronavirus, just found out this IFITM3 over and over again. Here's another article from recent journal article. We find a statistically significant number of hospitalized subjects show enrichment for IFITM3 allele. And so basically this is a protein that seems to be protective against those who are infected as far as preventing mortality. And so again, it's here. And another article I looked up as far as severe flu infections linked to genetic variation. So just again, not claiming that this is there is any genetic variation, but something has to explain this. There has to be, as you look across the age groups, as more Blacks are dying. So that was really kind of the takeaway for me. I know there's been a lot of talk about the disparity of Blacks compared to whites as far as the cases and the deaths. When you look here, Blacks are, like we said earlier, only about 14 to 15% of the population, where whites are 75. So why does Blacks have such higher rate of deaths? But we would expect to see that similar among Hispanics. and particularly in the older populations. And so I think that was one of the takeaway points for me is looking at health disparities with the places, where we're showing, where we live, eat, work, and play, as stated earlier, Blacks and Hispanics have similar rates of obesity. Blacks and Hispanics have similar rates of diabetes, but not COVID-19 deaths. There's something going on. Only about 54 of this sample of Hispanics passed away versus 4 times as many among Blacks. And so went back to my presentation. Let's see if I can get this back on the screen here. Display settings, swap, and let's see if I can.
If I can just interrupt while you're switching screens for one moment.
Absolutely.
And I just want to give everyone an opportunity to, raise their hand virtually and say that they were here. So I'm posting a link in the chat. It has a form for you to mark what class you're representing so I can get that info to your instructor so you can get extra credit. If you're in multiple classes on the list, check those boxes. And I'll be closing that in about 10 minutes. So I recommend you just hop in there now and check your box and plug in your name so that we can get that info to your instructors. So again, I'll be closing that at, let's say 1:45.
Excellent. Thank you very much, Chelsea. Thank you very much. So thank you for bearing with me through scrambling through the various tabs that I had open on my browser. But just to take it back to the presentation outline, we started off with 4 questions. And as I, reached the end of the presentation, it just, I couldn't, let me scroll back up so we can go through these questions here. Apologize for making you dizzy. This was just all in real time. What is the data? Well, we showed that the data shows that a higher rate of COVID-19 among older populations, and particularly deaths among Blacks, among older Blacks. That's what the data is showing, that there's significantly higher risk, not only compared to whites, but also compared to Hispanics. That was one of the biggest takeaways for me, that this this disease is not behaving like some of the other diseases, which are there are socioeconomic predictors of, and what we typically target with health disparities, such as obesity and diabetes. We saw a very, very different pattern among Blacks and Hispanics. Why is the data still unclear? And again, we saw it in the testing, we're missing over half of the data. And that's just a pretty, basic fundamental element to have. And without knowing the why, we really can't go to 3. We really can't talk about how we can use the incomplete data without, having further insights there. But we can talk about 4. What additional data do we need? And so I just came up with some questions. We need complete testing data by race, ethnicity, as we, indicated earlier when we started, in order to really draw conclusions to make sure that, for instance, is a higher rate of deaths among Blacks, to show they're disproportionately being tested. We would expect to see a higher number of cases and deaths among a certain population if they were being tested more, right? If that would just make sense. But so we need to have data on that. And this is just an idea. Let me see if I can get my pointer options. Laser pointer. And again, I'm not an infectious disease expert, but we need to know data on whether or not the influenza vaccinations are protective against mortality due to COVID-19. Something's happening. Something is happening in the nursing homes. Something is happening among older Blacks. As we saw the article earlier, Blacks have been less likely to be vaccinated against traditional flu, and in a nursing home, it's showing that it's concentrated there. But why is that not happening for other populations? And so I don't think that there is a strong link here. But at this point, I would much rather cross a question off as being no, as opposed to not asking it at all. And for the third thing that we need socio-demographic data on nursing homes and residency data among persons age 50 and above. Specifically, why are there other factors? I mean, we saw the tremendous disparity on individuals age 50, particularly among Blacks, who are much more likely to die above that age compared to whites and Hispanics? Is there something else? Is there a lower level of income or education, or is there something else on this driving that? Or are blacks more likely to go to nursing homes? Are those nursing homes less? Is there something about these the living arrangements of older persons that make blacks much more likely to die of COVID-19 compared to other populations? And number four, this thing is so new. We need to know whether there's a genetic factor involved, such as with the traditional flu that's been protective against not necessarily infection, but against mortality that's associated with COVID-19. Again, just want to look at that disparity of why are older blacks much likely to, even when the cases were similar among blacks and Hispanics, blacks are dying at a much higher rate compared to other races and ethnicities of COVID-19 above the age of 50. And with that, I think that we can open up to questions. We're right at 3:40.
All right, we have one question. In the Illinois column chart showing the death rates for age 80 plus, there are still around 40 cases where the race ethnicity is left blank. To what extent do you think those left blank cases could disproportionately represent Hispanic individuals?
Great question. Great question. We don't know. I can speculate all day, but until I get on a call with somebody, have a sit down with somebody from the Illinois Department of Public Health, I don't know. I mean, this is shocking to me, and it should be shocking to every researcher. I mean, as far as just testing, we have 50% of the race ethnicity field just left blank. I don't know what to do with that. I don't know, and especially when you look at patterns where black is closer to that population of 4. That's striking to me. Why is whites are 3/4 of the population? Is this are these whites here? Or is it Hispanics? It's only about a third of it. I can speculate, but I don't have any. I wouldn't be. It would just be pure speculation. It wouldn't be based on any sort of the data for COVID-19. I don't have any reason to believe why whites, blacks, or Hispanics would be more or less likely to report their race or ethnicity on these forms.
Okay, do we have more questions to be submitted via chat? We have, is it the individuals completing the test or those taking the test that are leaving it blank for the missing data?
Another great question. We don't know. As when we go to you look here at the asterisks on the total tests performed. I know the print is a little small, but there's a total number of tests performed and reported electronically for testing of COVID-19 at the, I presume this is Illinois Department of Public Health, this acronym here, commercial or hospital laboratories. So performed and reported electronically by IDPH and commercial and hospital laboratories. That's all it says. There is not a lot of information on who's reporting this data. And again, as you saw from the beginning of the slide, this is only one of 2 states, Illinois and Kansas being the other, where we would have race or ethnicity data, but even among the state, it's still limited. A great question.
Does anyone want to submit any more questions? We have some comments here that it's stunning that race ethnicity is not reported on deaths, that there was a certain percentage there that was not accounted for. And we have a question from a student or attendee here asking, why aren't more states reporting on this kind of demographic information?
I don't have if I were an elected official, I would be responsible for answering that question. But I don't really, and usually, for a lot of the public health, we have obesity and diabetes, we will have that information, but I think this is such a novel condition. And so just, I think things are just very, I don't think there's anything nefarious. I don't think it's, intentional. I just think that this is something that a lot of people just weren't prepared for.
Okay, we have another question here. I know that you are not a geneticist, but how impactful do you think genetic testing of the general population could be for future health endeavors and statistic gathering?
I think it's essential. I think that when we talk about determinants of health, all of a sudden we talk about places where we live, work, and play and are educated. And yes, we have decades of literature which shows that our socioeconomic and social demographic factors, have a very strong impact on our health outcomes. But as we see the case in point here, a lot of those things are, that Blacks and Hispanics, with obesity and diabetes, they have parallel outcomes. This is not what we're seeing here. Blacks are 4 times as likely to die at age 80 or 40, and even at some of the younger ages groups compared to Hispanics. So there's something going on here. And so I think that, genetics, even if it's not the root cause, we need to be able to at least ask that question. Is it something similar to sickle cell, or even with the ITM3, we need to be able to, to examine it and to rule that out. So I think it's very important.
Great. Okay, we have several more questions here. If you have the time, we have. Do you think that there is a good margin of those remaining home and not pursuing hospital care or testing that could skew the data?
Those who are remaining home and they were not, I think that we have a lot of elements that could skew the data. I think it's one of the earlier slides talking about a representative sample, and that's one of the questions that I have, right now. I mean, where obviously we can't do a randomized controlled trial. That would be the gold standard, try to figure out really how this test is, what's going on. But, even now, somebody, there are only tests, come into testing if you're sick, if you're symptomatic. So we don't even have, as far as testing goes, a representative sample there, so it could be a skewing of the results of those who are being tested, or those who are much more likely to be symptomatic and sick. So you're going to have I don't want to say an artificially high, but you would have a higher number of, cases, attributable to those, because those who are not, or who have mild symptoms are not reporting. So it could be said that, the case rate is higher. And also, in addition to not being a geneticist, I am not an expert in death certificates. I don't know. I don't know whether or not there's been a lot of talk of, talk and evidence that individuals who suffer, who die from COVID, have underlying health conditions, or who are older. As we can see here, we look at, confirmed cases, whereas, fairly split across the population. We look at deaths. I mean, this is a disease of older populations. This is a disease of older Black, populations. And so, understanding that is, recognizing that it's going to be important.
And someone asked too, not sure if this is your area of expertise, but do individual states receive test kits through state government or federal? Would this be why we aren't testing right now as much as we should be?
If we can just pause on that question for a little bit, because I lost my train of thought on that previous question. So again, I would love if there's someone who's an expert in death certificates. So let's say you have an elderly person who has multiple chronic conditions. Let's just say, obesity and diabetes in its later forms, but you also have COVID-19. Where does that determination get made? Where does that determination get made that whether we're going to put diabetes on a death certificate, we're going to put COVID on a death certificate, we're going to put, renal disease or cancer, or the number of multiple chronic conditions? Who makes those decisions? I just don't know. And are those decisions being made in a uniform fashion? But we need to have answers to those questions so that we can make sure that this just isn't artificial, that, we actually have those rates. And Chelsea, can you repeat the other question for a second? I'm sorry.
Yeah, there was a question about testing and if we know whether or not individual states are receiving test kits through state government, or is that federal? And would this be, the distribution of test kits or the ineffective distribution, would that be why we're not testing as much as we should?
We need to have a task force on testing. I think that just in addition to not being an expert on testing, you're like, well, Desmond, what are you an expert on? You're not an expert on anything. No, but just just the various types of. I know that from understanding from previously, it would take several days or weeks for a test to come back, and now we have several tests that can take a few minutes. So just that tells me there's a wide variety in the types of testing, various companies and organizations. So until we don't have consistency first in just the type of test, let alone the people who are delivering the test or the municipalities who are, or the interpretation of those results, we don't even have race, ethnicity on over half the tests. So the data right now, I would just say is incomplete until we can get some kind of apples to apples comparison of you have people doing private tests and at home tests. So again, similar to universal genetic testing, I think that this pandemic speaks to the importance of just having universal measures in place so that we can do widespread testing of not just those who are the sickest, but among everyone in the population, so we can really get a handle on what the data is telling us.
Great, and we've got a few more questions here. Here's two questions that kind of seem to go well together. It says, I'm not sure if you had a chance to review the data for Kansas, but is the racial disparity between African Americans and Hispanics similar to Illinois? As a follow-up, how can public health departments be encouraged to share this data that breaks down demographic info?
Great question. Haven't had a chance to review the information for Kansas, but that is next on my list. And what was the second part of the question, Chelsea?
The second part was, how can we encourage our public health departments to share this type of data? I'm not sure if that comes from the inside as someone who's involved or from the outside, but if you have any advice that speaks to that.
I think that there will be a lot of lessons learned from what we're going through. I think that just one, and I probably should have opened with this. I mean, we're in an exciting time, guys. It's trying times, it's tragic times. It's really forcing us in a position. I mean, I can't remember a time where we've had St. Patrick's Day canceled and Easter essentially canceled within a year. I can't remember just universities and schools and whole municipalities just everyone worked from home. Everyone learned from home, and so I think that there will be a lot of lessons learned. I think that sort of apples to apples comparison across municipalities, the sharing of the data, especially bordering states. If everyone's collecting different types of data in a different fashion. I mean, we go back to the earlier slide, even from Hopkins. Only 2 states are doing testing. And then different number of states are, reporting on mortality and different forms of reporting on cases. It's going to be challenging, but also too, those who work in research, we know it takes a long time to collect data. I mean, when you're doing analysis of healthcare programs, I mean, usually you're doing the lag time to 3 to 5 to 10 years just to, collect that data. So I want to applaud our municipalities for having, especially Illinois and Kansas, for having that kind of real-time daily updates of information, because in my primary work, I work a lot with data and evaluation. I can tell you data can be messy, especially, and we're just talking about even just with local programs. So you're talking about statewide and national to try to get it updated in a real time. I mean, it's no exaggeration, and you're working on data lag time of several years, and then you're having meetings with the experts of the state on how to clean the data and what this means. So despite the limitations in the current data, I think that the municipalities are doing a fabulous job, and I think some of the lessons learned from this will be some sort of national, real-time or tracking a monitoring system. But again, I think that we definitely need to applaud ourselves for the data that we do have.
On the heels of that is a relevant question. Will this type of research be something that CMS or CMMI might put out calls for? This seems like almost basic surveillance.
I don't have a crystal ball, but I would be surprised if something more that did not come for this. I know that we have our task force, and I've had the pleasure of working with some of the individuals on that force, both directly and indirectly during my time in Indiana. Ms. Seema Verma, to a lesser extent, Vice President Pence, and Secretary of Health Jerome Adams, and I can tell you that you have top-notch, hard-working individuals, the best of the best, just from the personal and professional interactions. You have the best of the best, so you have the best minds working on this, and I know that they will do. There will be leaders, and will do what is going to be protecting and promoting the health of the U.S. population. You can guarantee that.
And just a couple more questions here. Do you think as time passes that cases where race ethnicity is left blank will be officially categorized into a certain category, or will they stay unknown? And I might add onto that people who identify as multiple races too. How is that gonna affect the data? So we're just throwing a lot of balls at you.
I'm not a data expert. I'm not an infection expert. You know what? Well, I can just surmise that some of unless we have a way for the data that's already been submitted to go back to those individuals to figure out, is it a matter? So we have to answer the question: is this a matter of individuals just neglecting to put their race ethnicity on the form, or is this some sort of systematic where they didn't code it, they had a categorical variable when they're supposed to have a numerical variable, just something in that. I think that we did have data on age on that, so just the fact that there was so much missing from that. I definitely think just in general surveillance will increase, and I think that the data that will come down the pipes from this, from not just the days, months, and weeks, and years ahead. I can definitely foresee many dissertation topics on this, not just with the health disparities, but just the rural versus urban, just many things to come. So I think that in the end, with each passing day, this is one of the richest data sets available. So no, I don't think that we'll have that kind of blank data going forward.
And then a final question is just wondering if you have any points of comparison for outside the US in looking at racial disparities for mortality rates. And I'm not sure the question was specific to COVID or just mortality rate in general, but just wondering if you had any points of reference outside the US.
That'll be on the next webinar. No, I'm just kidding. That is, we have, and these have been great questions, guys. I sincerely appreciate it. But I think that before we even get there, one, we have to know what's going on at home. We have to know what's going on with the states and the nation. And before we even target to other states, and I think that we have one of the best surveillance systems nationwide. I think that, again, despite the limitations, I am just, beyond pleased and just thrilled to have access to this real-time data, which typically you're, looking at things 5 and 10 years lag time. And I think that we've gotten spoiled a little bit. Well, we're getting daily updates. Illinois is presenting daily updates. Each state is presenting daily updates of data. I can't speak for every other country in the world, but I think that we're doing a great job. I know that Hopkins is doing a great job, and I know that our leadership is doing a great job of our national leadership of collecting that data and making decisions based on that. So we have to start at home first, and we'll set up task force and committees to make sure that we can do an apples to apples comparison with our neighboring countries.
Great. Well, I think you're absolutely right that this whole COVID business is going to probably change the way we collect data, and hopefully will improve our ability to analyze that data for public health and other reasons moving forward. So thank you so much for this presentation. It was really fascinating. And just so everybody knows, once I get this up online, it will be accessible through the webinar page on the CEH homepage. So that's boisestate.edu/CEH. I'll put it in the chat here. And we thank you so much for taking the time to put this together and presenting. So thank you so much, Dr. Banks.
Thank you, guys. Thank you, guys. And thank you very much for the questions. Thank you again to Dr. Smith for allowing me to present. to all my colleagues at Health Management Associates, and to all you students. I mean, this is a great time, and you know, just keep moving forward.
Thank you.
Thank you, guys.
Great. Thanks, Desmond. We really appreciate you being on the webinar. So good to see you, sir.
Great seeing you as well, Dr. Smith. All right. Take care. Happy Friday.
Okay. Take care.